I'm Matt Frederickson, England. I'm excited to be here with you tonight and talk about navigating the balance between physician documentation burden and accurate coding, and talk about different strategies to reduce documentation burden while also remaining compliant. As the healthcare landscape has become more complex, physicians are increasingly overwhelmed by the need to accurately document patient encounters, especially in systems like EHRs. While EHRs are meant to streamline documentation, they often increase workload by requiring manual data entry and repetitive tasks. With the implementation of EHRs, it has had some unintended consequences as physician documentation has become more burdensome. Concurrently, coders have a need to have complete and accurate documentation to avoid undercoding or overcoding or run into different types of errors. According to Evers, however, who reviewed a study, EHR time during some specific oncology consults was able to be reduced by 27% when structured documentation was introduced, but the overall burden still remained high. I want to give a little bit of background about why I am very passionate about accurate coding. I became a compliance officer, a regional compliance officer in July of 2006. Later became a chief compliance officer, which I still am today, in February of 2012. Now, I want to take you back when I first became a compliance officer. My first week as a compliance officer was very interesting, as the FBI came in and raided one of the physician clinics. They closed the clinic and they seized all the medical records. It was really interesting because as a new compliance officer, I didn't really know what I was doing, and this obviously fell on me. What I found out, however, was this physician was new to our organization, and prior to joining our organization, he had been practicing a certain procedure, and at one point that procedure did not have a specific CPT code. However, over time, there was a CPT code that was developed for the specific procedure he was doing, and he continued using the unspecified code. So the
Dr. Matt,
they gathered documents.
Yes.
we're getting some feedback, an echo.
And submitted as a federal crime to the FBI.
Okay, that sounded better.
Now, since this all happened before he joined our organization, he relinquished his position at the organization, and he had handled that on his own. And thank goodness I didn't have to deal with all of that. But it definitely was a eye-opener of the importance of coding and what can happen without proper and accurate coding. Coders face many dilemmas and challenges, and one of the fears of coders is overcoding. As we've seen before, when organizations have overcoded, sometimes it comes down to the individual coder who has miscoded things, and we've all heard the horror stories. That often pushes coders to undercode. While undercoding might seem safer and there's a fear of overcoding, undercoding can actually hurt the organization by leaving money on the table for legitimate services that have been rendered. Besides fear of coding, there's of course challenges because coders have to meet certain productivity standards. There's organizational hurdles to ensure and improve coding practices. There's also that step of people feeling like this is the way we've always done it, so there's resistance to change. And then you have to decipher the physician documentation. And physician documentation, it's essential that we understand this balance and use the tools available to code confidently and accurately. I really love this slide. It's a slide from 2001, so it's fairly old, and you probably can't see all of the different things in there, but there are so many different organizations and agencies that have oversight of the healthcare industry. So many, I couldn't even name most of, well, I could name most of them, but some of them I can not even name, but you can see that we are so highly regulated that of course there is fear of doing something that's inaccurate or inappropriate or illegal. As we talk about appropriate coding, one law that we need to be aware of is called the False Claims Act. Now, this law was implemented by President Lincoln and passed in 1863 during the Civil War. What was happening during the Civil War is many organizations were taking advantage of the government because the government needed a lot of material really fast so they could fight this war. An example of what was happening was some organizations, such as a bullet manufacturer, was trying to supply the government with bullets, and instead of putting gunpowder in the bullets, they were putting sawdust. And there were multiple different examples of things like that that were happening during that time. President Lincoln saw that this was happening, and of course, the government was paying for these services and items, and that wasn't right for them to be defrauded by these organizations. So he implemented that False Claims Act. Now, the False Claims Act has now been used a lot in healthcare, but one of the provisions of the False Claims Act is the whistleblower, also known as the qui tam provision, as we know that many times when something is being done illegal within an organization, somebody within that organization knows about it. So the qui tam provision allows a person within that organization to blow the whistle and sue their own organization on behalf of the government, and whatever the government recovers, that whistleblower can get between 15 and 30%. So there's a lot of incentives there for the whistleblower. Now, with the Lincoln Law, there are additional penalties. There are civil penalties where the government can $13,508 up to $27,018 per claim submitted that's inappropriate. So I talk about claims because that's what we do in healthcare, right? They can also get money back for their damages. So if we overcode something and the government ends up paying us an extra $100 because of something we've overcoded, they can request and make us pay back up to $300, so up to 3 times the amount of actual damages, and of course those civil penalties. And remember that those civil penalties are for each claim that's submitted. So if there's something wrong, then those numbers definitely add up very quickly. Also, with this law, we could be excluded from participating and billing and working with Medicare and Medicaid. There's also criminal penalties, and people can be criminally prosecuted for violations of the False Claims Act. There are a lot of things to think about as we think about the False Claims Act, and also the job of coding, looking at documentation. And really, we want to maximize reimbursement as much as possible, which doesn't mean that we want to do anything illegal or unethical, but we do want to ensure that organizations are paid for the services that they render. It's important that we do not overcode, we do not undercode, that there's appropriate documentation to support whatever is coded, use the most specific code based on the documentation, and then leverage different tools that are available like EHRs to cross-check our coding. I really like this slide because it's really a blueprint of a house, right? And I relate this back to the medical documentation. Having the blueprints of what we did with the patient is very helpful, and it really supports what we coded. If, for example, CMS wants to audit something, they like to see the ins and outs. They like to see those nuts and bolts of what we did with the patient and ensure that we are coding appropriately. Oftentimes, this is what physicians think they document. Instead of a blueprint that shows the nuts and bolts of the house, they provide a picture of the house. Although you can't see everything that's inside, you get a pretty good picture of what's going on. However, this is often what the documentation looks like as we want to code it and ensure that it's going out the door. Sometimes it's not so good, and it really creates challenges as we move forward and code and bill and collect for the services we've rendered to patients. Now, physicians, they often spend hours documenting outside of clinic time. A 2024 study by Apathy et al. Showed that after-hour documentation is a key factor contributing to physician burnout. Burnout rates are over 65% for US physicians. Not all physicians experience after-hours documentation the same way. Some find it flexible, but for most, it leads to mental fatigue, affecting patient care quality, and increasing medical errors. A national survey by Medscape in 2021 showed that 42% of physicians reported feeling burned out, obviously a little lower in 2021, but almost 80% said that it started before COVID, but 60% stated that there was just too many bureaucratic tasks such as documentation. When physicians are burnt out, their ability to provide quality care declines. According to Lux 2022, higher documentation requirements and coding expectations have led to increased medical errors and turnover, directly affecting continuity of care. Hospitals and practices need to balance the requirements for accurate data while recognizing the impact it has on clinical teams. As we look at increased medical errors, burnout has a direct correlation with higher rates of medical errors. Apathy 2024 found that cognitive overload, which results from documentation burden, leads to mistakes that could compromise patient safety. Burnt out physicians are less able to focus and may overlook important clinical details. The Medscape 2021 survey that is cited by Lux in 2022 revealed that burnout was associated with a rise in major medical errors, particularly in highly regulated environments where documentation requirements are more demanding. There's reduced patient satisfaction. Physicians suffering from burnout may exhibit less empathy or attentiveness during consultations, negatively impacting the patient experience. As patients' engagement drops, satisfaction scores decline, which affects an organization's reputation and could lead to patient attrition. Also, it affects payment. Studies indicate that patients can sense when a provider is disengaged, leading to lower levels of trust and satisfaction. This impacts healthcare ratings and long-term patient loyalty. There's decreased continuity of care. Burnout often leads to higher turnover among physicians. This constant turnover disrupts the continuity of care for patients, which is especially crucial for chronic disease management. As healthcare is built on long-term relationships, disruptions can lead to lapse in care and poor outcomes for patients. High turnover rates also burden healthcare systems with the cost of recruiting and retraining new staff, further straining resources and reducing care quality. There's the impact on organization reputation. Healthcare organizations with high physician burnout rates face challenges in maintaining their reputation in the community. Burnt out physicians are less likely to provide quality care, leading to negative patient reviews and a possible decline in community trust. In turn, this could impact the institution's ability to attract talent and secure patient volumes, both of which are critical to maintaining financial stability. This in turn also increases patient wait times. Physicians suffering from burnout often experience lower workflows. This not only affects the time that the physician spends with each patient, but also contributes to longer wait times for patients seeking care. Delays in patient care, compounded by documentation demands, can further exacerbate the patient's health conditions, creating a negative cycle of worsening outcomes. However, as most of us know, coding is at the heart of healthcare reimbursement. The coding directly impacts the financial health of hospitals and physician practices. Undercoding is a common issue. It results in lost revenue because we're not capturing the full scope of the services provided. On the flip side, overcoding poses serious risks, especially with legal compliance, which we'll dive into a little later. Finding the right balance is crucial. Coding has to be accurate, compliant, and reflective of what the documentation supports in the patient record. Of course, there's potential reputational harm when coding is not correct. Accurate coding is crucial not only for reimbursement, but also for tracking patient health outcomes and ensuring data reliability. Lux in 2022 emphasized the failure to code accurately can result in missed revenue opportunities and gaps in understanding patient condition. Coding accurately also ensures healthcare organizations remain compliant with CMS regulations, especially in value-based models that rely heavily on precise coding reimbursement. That's according to MOI 2023. Many EHR systems were not designed with the user experience in mind, and their complex interfaces make it difficult for physicians to quickly find the information they need. Ebers et al. 2024 found that even through structured documentation reduces some burden, poorly designed user interfaces still create inefficiencies. Physicians may need to click multiple screens and menus to access or input data, significantly slowing down their workflow. This continues to create frustration and cognitive overload, leading to burnout. Of course, there's the issue of redundant data entry. One of the biggest complaints from physicians is the need to re-enter the same patient information multiple times across different sections of the EHR. According to Kaizuka in 2022, EHRs often require physicians to duplicate data entry, especially when the information is already available somewhere else in the system. The redundancy wastes valuable time that could otherwise be spent on direct patient care. Solutions like integrated data capture and templates can help mitigate this issue. Poor interoperability. EHR systems often don't communicate well with each other, creating a fragmented flow of patient information. For example, a patient's record from one hospital may not be easily accessible in another healthcare system. This lack of interoperability forces physicians to manually input or retrieve data, further increasing their workload, according to Evers 2024. Improving interoperability between EHRs can significantly reduce the time physicians spend searching for patient information, leading to more efficient workflows. Of course, there's also unnecessary alerts and notifications. Many EHRs are equipped with automated alerts that notify physicians about potential issues like drug interactions or incomplete forms. However, the sheer volume of these alerts often leads to alert fatigue, where physicians start to ignore the notifications altogether. This constant barrage of alerts can distract physicians from focusing on their patient care tasks, leading to potential safety risks. Simplifying alerts and allowing customization based on clinician preference can alleviate this burden. There's increased administrative work. Despite being marketed as tools to streamline clinical workflows, EHRs have often added administrative complexity. Physicians now spend a significant amount of time completing administrative tasks that are required by the EHR system, but offer little clinical value, according to MOI 2023. In a 2024 study by MOI, it was noted that documentation time increases substantially because EHRs are designed to meet compliance requirements, not clinical workflow needs. This mismatch is a significant factor in burnout. There's, of course, billing requirements. Billing EHR systems are optimized for billing rather than clinical care. That is often felt by many physicians. Then there's really a need to just simplify the EHR designs to focus more on clinical needs rather than administrative requirements, which could help reduce the physician burnout. One of the most effective ways to reduce the time spent on documentation is through the use of smart templates. These are customizable forms that allow physicians to input relevant information quickly without having to retype common phrases or search through endless drop-down menus. Kaizuka 2022 emphasized that using templates optimized for specific types of visits like follow-up or chronic condition management can significantly reduce the documentation time. By pre-populating these templates with relevant patient data, physicians can review, update, and finalize their notes more efficiently. There's adoption of other technologies such as voice recognition. Integration of voice recognition tools into EHRs allows physicians to dictate their notes instead of typing them. This can be especially useful during patient consultations, establishing real-time documentation while maintaining patient engagement. Ebers et al. 2024 mentioned how this technology combined with structured templates can help physicians focus more on patients. While voice recognition software has been around for a while, its accuracy has improved significantly, making it a viable solution for reducing the documentation burden. Standardizing data collection is another way to reduce the documentation burden, and it is by setting standardized fields for common data entry points such as patient demographics, vital signs, routine visit information, etc. Standardizing what needs to be documented reduces variability and ensures that only essential information is captured. Ebers 2024 noted that standardized data collection methods could lead to fewer errors and faster documentation times. Standardized workflow also make it easier for physicians to transition between different cases, reducing cognitive load and the need for customization on a case-by-case basis. Another important strategy is conducting regular audits and reviews of documentation workflows. Healthcare organizations should review current documentation practices and remove redundant or unnecessary steps. According to Kazuka 2022, many documentation requirements are outdated and are no longer needed, but continue to be persistent due to the habit or lack of review. Kind of going back to that first slide, that's the way we've always done it here. Encouraging feedback from frontline clinicians can also lead to identifying bottlenecks and pain points in documenting workflows, allowing organizations to adjust their systems and reduce the burden. Auto-populating fields based on existing patient data can save time. For instance, routine information like allergies or medication lists can be auto-filled from previous visits, allowing physicians to focus on new or changed information, according to Moy 2023. This approach reduces redundant data entry, making workflows more efficient. Some organizations have successfully reduced the documentation burden by employing medical scribes or virtual assistants who handle real-time data entry, allowing physicians to focus on patient care. Scribes often are not adopted because of their costs, but scribes or AI-powered virtual assistants can capture detailed notes during consultations and input them directly into the EHR system. This method can be especially effective in high-volume practices where documentation time directly impacts patient throughput. Training programs tailored to help physicians maximize their efficiency of their EHR usage can also alleviate burden. Many physicians are not fully aware of all the shortcuts or features available in the EHR systems, which leads to inefficiencies. Regular training can ensure that they are using the technology to optimize the use of the EHR. Encouraging peer support and training sessions can help physicians share those best practices and improve overall efficiency in documentation. So as we look at what does AI-enabled clinical documentation look like today, many practices leveraging innovative healthcare IT technologies are already finding success with AI-enabled medical documentation tools and services. These include technologies like dictation tools for clinical documentation and mobile optimized voice assistance tools. And some clinics are beginning to experiment with emerging technologies like ambient clinical documentation. One of the things that we have been trialing within my organization is that ambient clinical documentation. So within the room, within the consultation room, we place several microphones and it captures the conversation between the physician and the patient. This technology is able to remove things that are unimportant, such as if they are talking about the patient's most recent vacation to Hawaii. However, they capture the most important clinical information provided by the patient. These tools have, as we've trialed them within my organization, it has helped some of our physicians who may have not been so timely in their documentation improve their documentation times significantly. According to Athena Health 2024, like many AI-powered tools and services, advancements in clinical documentation are impressive in terms of their precision and the efficiency they provide. However, the healthcare industry is still exploring how to best utilize these powerful technologies and determine the challenges that are most effective in addressing. One application is predictive provider actions. By using predictive analytics or machine learning, platforms with EHR capabilities can analyze past data to identify patterns and forecast the most likely actions a physician would take, suggesting those actions. This not only saves time, but also integrates data analytics into workflows in a way that may improve patient outcomes. Data duplication, another benefit use of automation is cleaning and reconciling data in a patient's medical history. For example, some healthcare platforms with EHR systems are incorporating automation to scan patient records for duplicative information such as repeated medications. This type of automation ensures medical records are accurate, up to date, and minimizes the risk of medication errors due to data inaccuracies. Of course, I already mentioned the ambient documentation, and that is showing promising results. It's important that we look at the documentation burden we place on physicians, both from things in the past and things that may come up in the future. One recent example I wanted to provide of this is the code G2211. So this is an add-on code for new and established patient E&M services. This code can be used primarily with primary care physicians who have an established relationship with the patient, who has ongoing care needs, and the primary care or appropriate physician has ongoing coordination duties for that patient. It goes much deeper than that. But one of the first things the coding team wanted to see was for the physicians to document that they have an ongoing relationship with the patient and to code the G2211 code. However, according to the guidance in the Medicare Learning Network Matters, how to use the Office and Management Code G2211, they state that you must document the reason for billing the E&M visit. The visit themselves would need to be medically reasonable and necessary for the practitioner to report the G2211. However, in addition, the documentation would need to illustrate medical necessity of the visit, but CMS has stated that there is no additional documentation that they need when an organization is billing the G2211, that the medical record documentation that's already established would confirm the medical necessity of the visit and the appropriate use of the G2211. So as we look at different codes, of course, we didn't want to add on an additional burden. There could have been a short phrase that was created. And I know a lot of times we just think, oh, it's one little thing. It's not too much. But as we add on one little thing that's not too much, every time something new comes out or even things in the past, that just increases that documentation burden for physicians. I wanted to speak to another situation that happened in regard to coding and the physician burden of documentation. This relates back to E&M coding for emergency department physicians. What had happened is benchmarking data showed that there were opportunities to code things at a higher level. The medical director was upset with the coding because they assumed that there were opportunities to increase increase the coding levels so that higher reimbursement would be achieved, and they were already providing the services. The coding team wanted more documentation. Now, as we looked at the documentation, and I know this is an eye chart, but I will zoom in on something here in just a minute. One of the things we found is this was produced by the American College of Emergency Physicians, and it shows different examples of things that they believe should be coded at certain levels within the documentation. Now, as we look at the level 5 requirements, one of the things that you see in the red here are some of the things that they believe automatically qualify for a level 5, CT scan with IV contrast. And the reason behind that is that there's risk to patients when making that decision to give that IV contrast. Now, what the coders wanted, and there's other examples in here, is they wanted the physician to document that there was risk in making that decision every time that they ordered a CT scan with IV contrast. So as we looked at that, we didn't want to, again, increase the physician burden. And you also see in here that there is administration of sedatives, different medications. What we did is on the side of everything is we looked at peer review information and looked at if something was always or never or sometimes risk. And if we could document something was always a high risk of morbidity from the tests or medications that were ordered, we were able to document that, use peer review articles to support that, and maintain that document, and then direct our coders that any time that a certain medication or the CT scan with IV contrast was ordered, the physician didn't need to document the high risk of mortality or morbidity and mortality because we already have that documented organization-wide and we maintain that. Again, that's just something we did to decrease the administrative burden on physicians. Now, we did this thinking about the different national efforts that have been put into place to help decrease the administrative burden of documentation. The 21st Century Cures Act, which was signed into law in December 2026, include provisions aimed at reducing physician documentation burden. One key aspect of this law is to focus on interoperability and information blocking, designed to make electronic health records systems easier to use and improve the flow of information between healthcare providers. The Office of the National Coordinator for Health IT, through this regulation under the Cures Act, aim to streamline the use of EHRs by ensuring systems are more user-friendly and do not have unnecessarily required repetitive documentation. Additionally, efforts under the CMS Patient Over Paperwork Initiative align with those goals, focusing on simplifying regulatory and administrative burdens on healthcare providers, which includes reducing physician documentation. These efforts are aimed at reducing the time physicians spend on EHRs, allowing them to focus more on patient care and less on administrative duties. This Medicare's CMS launched the Patients Over Patient Initiative in 2017 with that goal of reducing administrative burdens on healthcare providers. Some key points CMS emphasized about patients over paperwork include reducing administrative complexity. CMS recognizes that overly complex regulations, redundant documentation, and excessive reporting requirements create unnecessary burdens on healthcare providers. The initiative aims to simplify policies and reduce administrative tasks, particularly around documentation, focusing on reporting and compliance. CMS also wants to ensure that administrative requirements add value to patient care. By reducing documentation reporting burdens, the initiative seeks to allow providers to spend more time focusing on quality care, improving patient outcomes, and interacting with patients. Provider input and engagement. CMS sought feedback from healthcare provider patient, and stakeholders to identify specific areas where administrative burdens could be reduced. This collaborative approach was intended to ensure that reforms were both practical and impactful. EHR usability, we've already kind of talked about that with the CARES Act. Regulatory streamlining, CMS has revised or eliminated outdated or overly complex regulations as part of the initiative. For example, they have adjusted documentation requirements for the E&M services, allowing clinicians to spend less time documenting patient visits and more time on direct patient care. The overarching message from CMS is that patients over paperwork is designed to relieve the regulatory burden on providers, allowing them to devote more time and resources to patient care, which ultimately benefits both patients and healthcare professionals. Task delegation is another way to help reduce physician documentation burdens. Physicians do not need to handle all aspects of documentation. Many routine tasks, such as updating patient demographics, entering vital signs, or documenting patient history, can be handled by non-physician staff like nurses or medical assistants. According to Kaizuka 2022, task delegation is a key strategy in reducing the administrative burden on physicians. This not only reduces the time physicians spend on documentation, but also allows them to focus on more direct patient care and complex decision-making. Collaborative documentation is very important. In team-based care, collaborative documentation involves multiple care team members entering relevant data into the EHR at different stages of the patient encounter. For example, nurses can document patient vitals and history before the physician enters the room, while administrative staff can complete the remaining paperwork after the visit. LUTS 2023 highlight that this collaborative approach enhances workflow efficiency and reduces redundancy. Physicians can then review and finalize the documentation, ensuring that all important information including without having to do it all themselves. This model ensures that all relevant data is captured while distributing the workload across the care team. Pre-visit planning is another strategy to reduce documentation burden. In this workflow, non-physician team members can collect and enter patient information before the physician sees the patient. This includes updating medication lists, reviewing lab results, and preparing any necessary documents or forms ahead of time. This approach minimizes the time physicians need to spend reviewing past records during the patient encounter. This allows physicians to enter the visit with updated, accurate patient information already documented, enabling them to focus on clinical aspects of care. Post-visit summary by team members is another strategy to allow nurses or other team members to complete post-visit documentation. After the physician has seen the patient, other team members can enter post-visit summaries, including any follow-up instructions or medication changes, ensuring the visit documentation is complete without requiring the physician to input everything personally. This reduces the time physicians spend finalizing patient charts, which is one of the main contributors to after work hours. That also helps ensure documentation is completed promptly, leading to better compliance with billing and regulatory requirements. Of course, training and workflow standards, we've kind of talked about that a little bit, but successful team-based documentation requires proper training and standardization workflows. All team members need to be trained on how to use the EHR efficiently and understand what data they are responsible for documenting. We've a lot of the ways in which to reduce the physician burden of documentation throughout this presentation, but I want to highlight a few of the things. Of course, the first one is to regularly review the documentation requirements. A lot of times the documentation practices are legacy and they no longer serve a clinical or regulatory purpose. Eliminating unnecessary documentation that doesn't contribute to the patient is very important in reducing that physician burden. By simplifying the required field and focusing on current clinical and compliance needs, physicians can significantly reduce this time spent on paperwork and administrative tasks. Streamlining compliance and regulatory changes. Healthcare organizations are frequently adopting new regulatory guidance from organizations such as CMS. It's crucial to ensure that these regulatory requirements are integrated into the workflow without adding unnecessary complexity. By proactively incorporating regulation changes, organizations can streamline workflows rather than add additional burdens. Providing clear guidance on new documentation standards and offering providers on how to efficiently meet the requirements can minimize the documentation burdens. Utilizing checklists and standard protocols. Implementing standardized checklists for common procedures or patient interactions can help reduce the variability in documentation practices and ensure that all relevant information is captured. These checklists guide the document process, ensuring nothing essential is missing while reducing over-documentation. Moy et al. 2023 found that standardized protocols can significantly reduce errors and ensure that only necessary data is documented. Minimize duplicative data entry. We've kind of talked about that already. Of course, there's other things that can be done, such as eliminate redundant data points, use pre-filled forms for routine visits, and customize templates for specialists and physicians with routine loads. Throughout this presentation, we've explored the growing burden physicians face due to extensive documentation demands, which leads to burnout and negatively affects patient outcomes and patient care quality. In addition, we've looked at how inaccurate or incomplete coding can have a significant financial and clinical impact. As healthcare systems become more data-driven, striking a balance between maintaining accurate coding practices and reducing documentation burden is critical for both physician well-being and organizational success. A key takeaway from our discussion is that technology plays a pivotal role in reducing the documentation burden. AI-powered coding assists, voice recognition, and natural language processing can automate repetitive tasks and simplify workflows. Moy et al. Demonstrated how AI systems can suggest codes based on clinical notes, improving both efficiency and accuracy. By leveraging these technologies, healthcare organizations can reduce errors, ensuring compliance, and free up physicians to focus more on patient care. Focus on clinically relevant information. Simplifying document by focusing on clinically relevant information, of course, is another recommendation. Not all data needs to be captured exhaustively. Clinicians should document the information that directly affects patient care and outcomes. Kazuka noted reducing note lot can streamline workflows and make documentation more meaningful. By cutting down on redundant and non-essential data entry, healthcare providers can reduce the time spent on documentation without compromising care quality or compliance. Adopt team-based approaches. Another key recommendation is to embrace those team-based approaches that we just discussed in the last slides. As Kazuka pointed out, task delegation is an effective way to alleviate that workload on physicians while maintaining thorough documentation. Regular audits of documentation practices. Healthcare organizations, of course, needs to conduct those regular audits of their documentation workflows. I can't stress how important that is to eliminate some of those legacy documentation requirements. These audits can identify areas where unnecessary steps are being taken or there are outdated practices. Continuous improvement through audits will help organizations stay compliant with regulations while maintaining an effective workflow. We've talked about the tailored solutions for each specialty. Customization also improves the clinician satisfaction by reducing unnecessary steps. And then promote physician well-being. Beyond improving documentation, promoting physician well-being is essential. High levels of burnout can have long-term consequences, including increased turnover, lower job satisfaction. Organizations should prioritize strategies that reduce burnout, such as streamlining EHR usage, implementing flexible work arrangements, and offering mental health support. Addressing these root causes of burnout, such as excessive documentation and administrative tasks, will help retrain and retain skilled physicians, improve the overall quality of care, encourage continuous learning and adoption. Looking at those new technologies that are emerging is very vital as well. These are some of the references that I've used throughout this presentation. And I will now open it up to any questions. Thank you. One thing I wanted to add quickly is, with a lot of this technology, there are risks with it as well. And I didn't dive so much into the risks, but there's always that risk if someone's using some of those templated scripts that they're not updating to the patients. It could look like chart cloning, and that is a risk. And also with the AI, even though we are developing and expanding that as an organization, we found that a lot of AI tools that are for physicians that are being developed on the side are being targeted to physicians. In fact, I bet next time I scroll Facebook, it's probably going to show me some of those because I'm talking about it. But we've seen some physicians sign up for these services on their own, and then they are then sending protected health information outside the organization without the appropriate protections. So like everything, you have to have appropriate policies and procedures to ensure appropriate controls are there. Are there any questions I can answer?
I'm viewing the chat to see if we have any questions, but amazing presentation. And I really liked how you briefly touched on it just right there with the chart cloning. And so I was kind of wondering how you balance being able to shorten documentation time for providers while also making sure that the notes that they enter into the patient system is going to be unique to the patient. So is there anything that your organization in particular is doing to try to help alleviate that, or try to watch to make sure that, the information that's entered is unique to the patient and not just copy pasted?
Yeah, and that's coming along with that AI software that we're seeing more than anything else, as that ambient listening devices are being used. It's more of the AI capturing that conversation, and it's pulling in the information that's being shared. We're hoping to eventually also roll that out to our nursing staff. So, the expectation would be, if a nurse goes in to do insert an IV, the nurse is telling the patient, I'm going to be inserting an IV into your left arm. So they're telling the patient what they're going to be doing. That recording device that has the AI is going to capture that, do their documentation for them, and make it very specific to the patient. And then the nurse goes in to verify that it's accurate. Same with physicians. So we're thinking that this AI technology is going to help. We're trialing one with one company. We're going to be trialing another with a different company soon. Of course, there's costs that come along with that. Luckily, from a national standpoint, we haven't seen a lot of criminalization of note cloning. We hear about how bad it is, and there hasn't been a lot of prosecution on that, which has been lucky for a lot of organizations, because I'm sure most of us see it if we're in that role of looking at physician documentation.
Yeah, and it kind of ties into the next question that we see from Trapper Shiflet. I hope I'm saying your name right. But when you talked about the nurses being able to verify, or doctors being able to verify the information that's been input by ambient system, do you see AI completely taking over the role of coding, or a vast majority of it in the future, such as humans only intervening to check suspected errors?
It's definitely moving that direction. I don't know if that's scary or not, but it is moving that direction. I think it's going to depend on each organization and how they implement it, their funding sources. So probably for more technology savvy healthcare companies that are investing and have that money to invest, we're going to see that. For more rural, financially strapped organizations, we won't see it as much until it becomes cheaper, if it does become cheaper.
Let's see if we have any other questions. Okay, well, I don't see any other questions in the chat, so if you don't mind, I'll go ahead and share my screen again. And I think it's going to take me from the beginning, but that's okay. Here we go. Okay. So thank you all for joining us for tonight's discussion, and special thanks to our speaker. We would like your feedback on HP Cares. Please share your thoughts through this link that's listed here, and you can also use this little barcode thing here. It'll take you there as well. It'll take you to the same site where you registered for tonight's event. You can complete a feedback survey about this session along with obtaining a certificate of participation. And if you would like to view this presentation again, we'll have the recording by next week. Our contact information is provided here. If you have any questions, you can reach out to me at smorland1@snhu.edu or our program director, L. Ward, at snhu.edu. And we thank you for participating and joining our HP Care session today. Thank you so much. I hope you all have a good night.